Very good evening to all of you. As you can see, Jyoti Dev has constructed the program in such a way that we're all around and he's keeping us all occupied. I just saw Jayant trying to catch a running off somewhere, but then he's right back here into the hall all over again. So the session is for half an hour. Is Dr. Geetha here? Okay, good, perfect. So and because I'm the moderator, so what I would request is the three speakers they're already joined us here. The panel discussion is on issues and solutions in diabetes. I'm supposed to be talking on hypoglycemia. I'll leave myself to the end of because they're all, it's a mixed bag. There's no topic which is related to the other. So I'll start off with Dr. Geetha M Nair, who will be talking to us. She's from Trivandrum. And because this is in continuation of what was discussed just now in relation to chronic kidney disease, I think it's better if she continues in that fashion. She's the head and chief consultant in nephrology in the PRS hospital here, and she has presented papers, organized CMEs, delivered invited lectures at state, national and international level.
Thank you, madam, for the nice words, and also thanks to Dr. Jyoti and his wonderful team. We'll go straight away the topic because it is tightly scheduled. It is about dialysis phobia. Does dialysis phobia exist? Yeah, definitely there is something called dialysis phobia. The moment you tell a patient that you have got irreversible permanent stage 5 kidney disease or final uremic stage of kidney failure, the only two options that are available for patients are transplantation and dialysis. Suppose if there is, actually it is a life-changing moment. It's a life-changing event for a person when you say that you're going to have either dialysis or transplantation. If there is a live or donor, then you straight away go for transplantation after workup, and if not, you go for, if he is fit for transplant, then you look for other options like disease donation. Suppose if somebody is unfit for transplantation, the only other option available is dialysis. So definitely, I think that's a devastating phase in a person with renal failure. That phase is quite important. See, what are the causes of this phobia? To dialysis. Initiating renal replacement therapy, dialysis. There are two forms of dialysis: hemodialysis, which can be done mostly in our country, hospital-based hemodialysis with the help of either a AV fistula or a tunneled catheter. If it is permanent, it is tunnel catheter, or temporary catheters, jugular vein catheters are also used, or institution-based or home-based hemodialysis, which is not very common in our state, but there are people who are going for that. The other option, if you don't want to go for any machine, needles and blood compartments, if you don't have to touch the blood and all, then you can opt for a continuous ambulatory peritoneal dialysis, which can be done at the home environment, which is convenient, provided you have a caretaker. Some people, very motivated people, they do it themselves. So that is one part. So what are the causes of the phobia? The most important thing, I'll just rush through for lack of time, it is one knowledge gap, See, when a person is advised dialysis, he should be very clear what is the goal of this therapy. Why you are advised dialysis? That is just for sustenance. That is most important is sustenance of life. He has no other way. If you say clearly that that is the purpose of starting dialysis, they will accept after initial fears. So that knowledge imparting is very important. And they'll have so many apprehensions. What is the outcome? Unpredictable outcome. That's another important thing. So you have to consider all the comorbid conditions. When you start somebody, it is actually a multidisciplinary approach. You have to assess the cardiovascular risk, eyes, peripheral neuropathy, anemia, as Dr. Harikrishnan has said, anemia correction. All these things have to be there to get a good life on hemodialysis or hemo or peritoneal dialysis. So that all comorbidities should be addressed. That has also to be, the importance of adequate dialysis. Thrice weekly hemodialysis or 2 to 3 exchanges of peritoneal dialysis per day. That knowledge has to be given by the nephrologist or by a team of renal social workers or counselors. That is very important. It is for sustenance of your life. And many many a time they will have apprehensions. They might tell you, that a friend of mine was on dialysis for 3 weeks or 2 months and then he succumbed. So it is quite dangerous. You have to say that your profile is like this with all the evidences and patient condition. You have to explain very patiently that that person must have had a rapidly progressive, good pastors or vasculitis is a more dangerous category of renal failure. So that has to be addressed. Another important thing is that, finance is another, the finding cost for dialysis. As Dr. Manisha was mentioning in the morning talk, somebody, if on dialysis, if you have to maintain continuous ambulatory peritoneal dialysis, it easily comes to 30,000 per month. And for hemodialysis with erythropoietin or Darby or whatever it is, iron and all such things, it will come to 20,000 per month. That is also quite a huge sum for our developing country like India. It is quite difficult to manage. That's another thing. Now, another thing is in family issues. Many a time we think that, especially when these patients are the sole breadwinners, they think that I am supposed to support my family, but now I am a burden to the family. They have to support me and take me for dialysis thrice a week to the hospital. That pressure, then work pressure, to maintain the normal work culture and work profile, peer pressure, all such things. And also the complex procedure which involves multiple needles, drawing out blood, machines and frequent visit to the hospital. All this cause stress to the patient. But the remedy is, most important is imparting correct knowledge to the person that this is life-saving, and you can go ahead very well provided you address all your issues in a better manner with the help of our dietitian, all urologists, ophthalmologists, cardiologists, all people have to be included in your treatment schedule. You have to go for proper good dialysis. And also one more thing, finance management is also important. Nowadays the government has, in our state, we have Karunya scheme and RSBY. All these schemes supporting dialysis patients, they easily get more than 200 to 250 dialysis totally free of cost for patients enrolled in the government hospitals. And of course there are so many other private organizations helping out. Even in our hospital we have charity-based dialysis scheme. And I think at this juncture, I would like to tell you that somebody who is started on dialysis, somebody who is, when these physicians and all, somebody see diabetic patients quite early in the disease process, I think when they are working, these people are working, they should have some insurance scheme or something in their name, because as their disease progresses and they have as they develop multi-organ failure, it will be very difficult for them to get some insurance. So when they work itself, they have to be enrolled into some insurance scheme. That is also quite useful for them later if they develop some complications. And if you have to plan all these things, fistula, money, caretakers, all such things, you need to have time. So when the physicians, when they see progressive kidney failure, stage 3, stage 4 itself, you have to refer them to a dialysis center so that they can plan it and take the thing in a more relaxed manner. Of course, there are counselings, clinical psychologists, as well as if needed, antidepressant medications can also be given. And another important thing I would like to tell you is that if you give this knowledge correctly, that this is required for your life sustenance, you got all this help. After all this initial fears and apprehensions, they will fit very well into the dialysis family. After 4 or 5 sessions, they will be quite comfortable, and they that is another important job of the healthcare provider, the dialysis staff, the dialysis nephrology people, the dialysis staff, they have to give that confidence to the patient. And we see many times these people having these dialysis patients, they have an excellent rapport with the dialysis staff. Whenever we go there, we actually see them once, 2 or 3 times in a month for 10 minutes. And whenever we visit these patients in the dialysis room, the staff will be said that, madam, today we got laddu from this patient because that Lelava Chechi's cat delivered, or her son passed. All this, they share all their good and bad news, good happiness, or whatever it is there with the dialysis staff. And therefore, I'm sure with an excellent team spirit and excellent team support, all these phobias will disappear. Thank you.
To the point, and you stuck to the time. That's extremely important. Now I would request Dr. Narsingh Verma. So what we'll do is we're trying to stick to our 5 to 6 minutes each. So we have enough time for discussion, and the topics are all dissociated. So just keep your questions ready when we end. So Dr. Narsingh Verma is going to talk about the night shift workers and diabetes. He's professor. You were introduced in?
Yeah.
Okay, so I will not reintroduce. He's a dear friend. Yeah.
Thank you, ma'am. Night shift and diabetes are very well related, because you all will agree that in present time, even the developing countries like India, we are having various shift workers, not only in those fields where the shifts are there, even those who are not working in shift, they are working at odd hours. Those jobs which were 10 to 5 jobs, they have become 10 to 10 jobs because of the pressure of the work and the various changes in the lifestyle. So this all is affecting our life. At KG Medical University, where I'm working, we had a PhD thesis on this, night shift workers and diabetes. What we did this study in the nursing students. They were having the night duties in trauma center, and you know that trauma center works for 24 hours, and these night shift duties were having the 7-day night duties, and then day duties, and then other duties. So what we did their insulin levels at different times, and also the blood sugar levels, blood pressure and other things. So what was inferred by this study, that those nurses who were performing night duties during that time, they had more insulin resistance. By HOMA B, we calculated all this, and we found that their insulin resistance increased during the night time. And when they converted to the day duty again, it took some time to come back the original values. So what we can say, that night shift is already related to the increased insulin resistance. But this is not the only one story. Those who are not having diabetes, they can develop diabetes because of the night shift. Alternating shifts are more dangerous than the continuous night shift. Meaning by that, if somebody is having night shift for 3 months, 6 months, 1 year, that probably body adjusts, but alternating duties are more dangerous. It has been seen in that particular study. Moreover, those who are diabetic and having night shift, we have so many patients who are working in the night shift, and sometimes it becomes difficult, challenging to have their good glycemic control, because in these patients, sometimes when they are using insulin, especially in those patients, then we have to be very cautious, because in these patients, the best thing will be the basal bolus therapy. One basal shot, and then depending upon their meal time, we can introduce bolus. So I have few patients of these type in which this particular type of treatment is very effective. So the night shift can affect the new development of diabetes, especially those who are prone to develop diabetes, and also it can also have impact on those who are having diabetes, and their management of diabetes can also change because of the night shift. Not only this, those who are not in the night shift, but still they work for more night hours, they can also have this impact. If you ask me, I will say that the increase in diabetes which is seen in my country has also been largely contributed by changing lifestyle, especially changing our lark type of lifestyle to owl type of lifestyle. Our youngsters are having more nighttime job or nighttime studies, or they are working in the night, or just they do not sleep in the night. This are affecting their insulin resistance, insulin levels, more requirement of insulin, and other things. So in nutshell, I have not come with any slides. What I have seen, what I have read, what I have done, I am describing to you that night shift will worsen the control of diabetes. It will increase the new onset of diabetes. Thank you very much.
Thank you, Dr. Narsingh. I think we must congratulate Jyoti Dev for this topic, because I don't think it's ever been discussed in any conference, and I must congratulate you as well, because you've already been working on it. So first-hand experience is always extremely important, And I agree with you that this is a panel discussion. Ideally, we should not have slides, but just to set the ball rolling. So thank you. That was very, very well done. Thank you so much. So Jayant, the third talk here is obstructive sleep apnea, treatment and challenges. I think Dr. Jayanta Panda has already spoken earlier. He's professor in the postgraduate department of medicine, SCB Medical College, Cuttack, member of the Faculty Council, Indian College of Physicians, member executive committee, RSSDI, and academic council, Sambalpur University, and he has 62 national and international publications.
Thank you, ma'am. So, as already ma'am has told, it's mixed topics related to the different problems in the diabetes, and I'll be speaking on obstructive sleep apnea, the treatment challenges. All of you know that the basic problem in the type 2 diabetes is insulin resistance, and the insulin resistance is profound in patients who have metabolic syndrome, and metabolic syndrome comes as a cluster of obesity, type 2 diabetes, hypertension, dyslipidemia, and these are the patients with metabolic syndrome associated with insulin resistance who develop OSA or obstructive sleep apnea. So there is a very common association. Previously we are not very well aware about these phenomena, and gradually we are knowing more and more about this association. So these are the group of patients who have apnea and hypopnea related to stoppage of the respiration, increase in the blood pressure, increase in the blood sugar, and leading to catastrophe like a myocardial infarction or a stroke in the night. So there are different issues. I'm not going to the detailed part, only I'll tell you the treatment challenges. And as you know, the good sleep hygiene is very important. I'm not going to that because the interventions include the behavioral changes, mostly the diet, exercise, and the habits. All of you know that we have to allow our patients at least 8 hours to have a restful sleep. If patient is sleep deprived, not only that there is poor control of the blood glucose, also there are chances of comorbidities and complications. So the patient should have a regular time for sleep, a very conducive environment, and patient has to do a prudent exercise and avoid stressful situations. The restless leg syndrome is a part of the syndrome. The sleep deprivation is there, chronic insomnia is there, and sleep apnea includes the different risk factors. And this is a very important thing which I must tell before going to the treatment issues, that in a normal respiratory tract, the problem remains in the throat, and the normal respiratory tract, the air passes through. When there is a narrowing, there occurs snoring, and when there is a complete obstruction, the apnea takes place. The treatment which we are concentrating today includes the behavioral changes, the mostly weight loss. So obesity is associated with this obstructive sleep apnea. So mostly we train our patients for decreased weight by diet, exercise, and lifestyle, and that includes everything which you know by the discussions, which diet, the fiber-rich diet, and how the patient has to calculate calories, the carbohydrate count, and etc. Another important thing is the sleep position. You can ask the patient, those who are having obstructive symptoms, to sleep on one side and raising the head. At times they need oxygenation when there is oxygen saturation is low, especially in very obese patients, and patient has to be instructed to avoid sedatives and alcohol before going to the bed. CPAP is a very effective therapy and only therapy which is effective in 100% patients, and that needs motivation because it's a machine which you have to use every day while going to sleep, and you have to put the mask and the environmental air is delivered under a certain pressure so that this obstruction what I have shown is overcome. The CPAP is widely available, and many of you have seen in ICUs as a non-invasive ventilation and the instruments which we recommend to our patients. Surgery, there are few surgeries like tracheostomy, tonsillectomy, and pull forth mandible or tongue is practiced, but the last results, they should be reserved to patients who don't normally change their lifestyle or they don't improve with the CPAP. Finally, the dental appliances which also aim as a pull forth of mandible and tongue, and that also needs expertise and put as a last result. So the most important thing, the most important treatment challenge is lifestyle modification, the diet, exercise, stress management, adequate and proper quality of sleep, and those who are not responding, them we have to do a sleep study and ask for the CPAP before the patient is further prescribed for the follow-up. And if that is followed up, the obstruction is relieved and taken care. But the outcome is not very simple, as we have discussed, and there is a difficult outcome. On most of the patients, they find it difficult to change their lifestyle as well as get rid of these symptoms and ultimately face the complications related to sleep apnea. Thank you for the attention.
Thank you, Jayant. So we've been talking about a lot of drugs, which cause, which don't cause, which one to choose, and the two most important aspects of diabetes management when we discuss any drug is to think of weight gain and hypoglycemia. So the first thing you should be very clear about is how to classify it. So severe hypoglycemia is one that requires assistance. Documented symptomatic hypoglycemia would be symptoms plus plasma glucose less than or equal to 70. Asymptomatic hypoglycemia, unawareness, there will be no typical symptoms, but the plasma glucose is less than or equal to 70. Okay? Now, this is what the book tells us, but in the trials they've used different, like if they use 56. In the switch trial, in the leader trial, they've used different classification. Okay, so that why they have done that I will not be able to tell you, but this is what is the standard classification of hypoglycemia. It's common, 30 to 60% type 1 more than type 2, and the more intensive the control, the more lower the HbA1c, the more likely the chance of hypoglycemia, more so in the elderly, especially with the longer duration of disease, and nocturnal, extremely important. When we are trying to switch from IDEG, when we're trying to switch from liraglutide, I beg your pardon, when we're trying to switch the two insulins between switch 1 and switch 2, then with the deglutec and glargine, the nocturnal hypoglycemia was considerably less with deglutec. Now, I'll not go into the details of this slide, what I mentioned. I'll come to the drugs individually, but you'll be surprised to know that there are a lot of drugs which cause hypoglycemia. Now, this is a better classification. So, drugs that displacement from albumin binding are aspirin, warfarin, sulfonamides, trimethoprim fibrates. Decreased renal excretion are aspirin, probenecid, allopurinol. Decreased metabolism, warfarin and MAO inhibitors. Insulin secretagogues, aspirin NSAIDs, inhibition of gluconeogenesis alcohol, and increased peripheral glucose utilization. Again, so aspirin is there in several places. This is quite, I'm sure this would be a surprise to you. Amongst the sulfonylureas, this was a very elegant study that glibenclamide singly or with second hypoglycemic or potentiating agent, that was the majority in 63%. Then alcohol, propranolol salicylate singly or with another hypoglycemic agent was 19%, whereas quinine, pentamidine and disopyramide only 7%. As far as the sulfonylureas, which amongst the oral anti-diabetic agents are the most notorious, you can see that gliclazide is the least, whereas glibenclamide or glyburide has scores the maximum. And remember, when I spoke on sulfonylureas, safe and smart sulfonylureas earlier, I said they are all different. That is why the hypoglycemic potential, the attachment to the SUR makes the subtle differences in the hypoglycemia. So this is again some more data on glimepiride versus glibenclamide, much less hypoglycemia than the obstacle study I have already alluded to, in which the most commonly prescribed drug is 75% is glibenclamide, and in this study only 5 patients had the highest observed hypoglycemia score of 6, and the score that they had used was the Swanson score. So why do sulfonylureas lower? Well, we all know that is the mechanism of action. So is it actually a side effect, or can we say too much of an effect? So education, the need for education is extremely important. We have data from the advanced study, and remember this is excellent data in Indian patients, which was published, this Dr. Arvind's group, that sitagliptin and gliclazide had the same rates of hypoglycemia. This was done in patients on Ramadan. So what is the setting for hypoglycemia? If you skip or delay your meals, if you vomit and you've already taken your medicine after that, wrong dose, too high a dose, too little carbohydrate. And remember, inadequate food intake in this study is a major cause of hypoglycemia. Diabetic renal disease, could be adrenal insufficiency, high insulin antibodies, or development of an insulinoma as well. We know about the smoggy effect, we know about the dawn phenomenon as well, and we differentiate by a 3 a.m. blood glucose. In one, you need to hike up the dose of whatever medication, usually insulin. In one, you need to, smoggy, you need to step down, dawn, you need to step up. So iatrogenic hypoglycemia in type 1 diabetics is known. Again, similar factors. Here I'm just trying to highlight as to what is the individual cause in each of these cases. You're all aware of the symptoms, but remember, even despite this multitude of symptoms, it may be entirely asymptomatic. There are some symptoms which are mimicking other diseases. During sleep, late night, if you get a headache early in the morning, that is very, very suggestive of hypoglycemia. Symptoms are different in children. Management, you're all aware of how to manage if in a conscious patient, in an unconscious patient, the importance of glucagon and monitoring the blood glucose. The most important is prevention by readjustment of the drug dosage, self-monitoring, education regarding hypoglycemia. Alcohol is not a good combination with insulin. Always carry some carbohydrate, a medical alert ID, a glucagon emergency kit, and avoid meticulous control in patients with CVD and elderly. Thank you very much. I would like to ask Dr. Geetha regarding the dialysis phobia, what you said. Is it more with any particular type of dialysis, with a CAPD or with hemodialysis?
Usually in the home, they'll be quite comfortable. There'll be usually some bystander standing nearby. I don't think CAPD gives not that much of tension, and they don't have to touch the blood compartment of the patient, just instilling some fluid into the abdomen. Whereas hemodialysis, usually, even though it is under supervision and monitoring, I think since there is, that involves blood taking out, so many machinery and such things, and needle prick fear. Initially, the anxiety is more with hemodialysis.
Obviously, it's in a hospital setting. It's in a hospital setting, so that hospital phobia would be attached with that. Dr. Narsingh, what would you recommend as, there's no going back. If a person has a night, see all these train drivers, these guards and all, we can't change the occupation and that is a source of income for them. So but what would you recommend as to how we can overcome this problem of night shift workers and diabetes?
Ma'am, whether they are having diabetes or they are having risk for developing of diabetes, that will decide our strategy. If they have the more risk of developing diabetes, then the lifestyle intervention had to be started very early. Regarding meal becomes very important because these type of patient cannot get meal at their time of demand, and they have to take meal on the basis of their job. So we have to train them their type of meal and time of meal and also the quantity of the meal. That becomes very important.
So lifestyle alteration along with it, they know they have to live with it. Yeah. So that is extremely important. Obstructive sleep apnea, right? How would you diagnose it? I think it's very important for the
Actually, that is not my topic, ma'am.
No, I mean, I know
Yeah,
the treatment and challenges, but
yeah,
we will
yeah,
start
but,
treatment only
yeah.
once. Just a brief.
Yeah, actually, the first suspicion when the patient's attendants tell that the patient is snoring at the night.
Exactly.
So he has daytime drowsing or the sleepiness, and in the night, patient is having snoring, or there is spells of apnea where the patient is panicky, gets up, and air hunger type of symptom takes place. And those who sleep nearby the patient are in their room, they notice the symptoms and they come forward. We usually go for a somnography, polysomnography. We tell it a sleep study. We see the awake and the sleep waves. The REM and NREM sleep is recorded, and that denotes the sleep apnea and the apnea hyperpnea ratio, what is taken. That's can be mild, moderate, or severe. And accordingly, the treatment is suggested, and patient has to be examined. The most important thing, the hypersomnolence in the daytime, and in the night time, patient will have snoring or apneic spells as reported by the attendant of the patient.
Usually in the context of a patient who is already obese, that's extremely important, right? So the metabolic syndrome,
all components of metabolic syndrome
would already be there.
Obesity, diabetes, hypertension, they are all existing.
But the sleep study is extremely crucial to clinch the diagnosis, especially if you're going to use a BiPAP, etc. So, yes, please, we'll be happy to have some questions from the floor. Yes, please.
No, after the patient goes to sleep, that will continue. You see, what CPAP does, it delivers the air under a pressure. There is obstruction at throat. That air overcomes the obstruction, and the snoring or this bottleneck is overcome. So once he on the machine, puts the mask and goes to sleep, and only in the morning it is taken out. And by the time he has to practice weight loss, he has to practice the other factors what are can be correctable in the upper respiratory tract. So if patient gets over that, maybe requirement is lowered, or else patient needs throughout the life and throughout the night.
Night shift workers. Have you done any studies in industrial workers apart from the nursing?
Sir, at present I have done only in the nursing students, basically working in the trauma center. But I have planned to do in the traffic personnel and other, especially I have planned a study in those who are working in the, you can say, the job which are basically related in only talking to the others during the night time.
I would like to share some experience on this. I'm an industrial physician working
That's excellent. Yeah.
Working in a fertilizer industry, petrochemical industry. We have nearly about 30% of our working employees are pre-diabetic as well as diabetes. Those employees we do routine medical examination. They are found to have their insulin level also, hyperinsulinemia also is found. And those have the diabetic people as well as pre-diabetic people, they are having their fasting blood sugar on the higher side. And non-diabetic also, there is a vice versa. That is their fasting is higher than the postprandial in the next day to come. This is one thing, but we need some more grant or somebody to help to screen these employees for having, rather than having a night shift. Lack of sleep also induces this hyperinsulinemia as well as...
Dr. Narsingh addressed that issue.
Yes,
he pointed to that. Thank you so much.
Thank you.
Thank you very much. So we'll close the session and I'll pass the mic on to the organizers. Thank you very much.